Hello and welcome to the Multiple Sclerosis Association of America's live webinar, The Many Faces of MS, Exploring Diversity and Differences. My name is Peter Demiri. I am the Vice President of Programs and Services for MSAA and your host for tonight's program. Tonight's webinar is part of MSAA's MS and the Family campaign. I would like to take this opportunity to thank Novartis and Celgene for supporting this webinar and other campaign activities, including a series of educational programs, podcasts, and Ask Me Anything online chats. As you may know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. Listed here are just a few of our many free programs and services provided all across the country. I encourage you to visit our website or give us a call to learn more about our programs and ways we can help better manage your MS. And lastly, tonight's webinar will be archived on our website within a week or so at mymsaa.org. As you're watching the program tonight, we encourage you to ask questions about the presentation by typing them in the chat box on your screen. We'll have a Q&A session at the end of the program and try to fit in as many questions as time will allow. Also, if you have any technical issues with the webinar, please type your concern into the chat box and a moderator will reply to you. At this time, I am very honored to introduce our guest presenter, Dr. Mitzi Joi Williams. Dr. Williams is a board-certified neurologist and fellowship-trained multiple sclerosis specialist. She is a leading expert in understanding MS in underserved and ethnic minority populations and dedicated to raising awareness about the importance of research participation and encouraging diversity in clinical research. Dr. Williams, thank you so much for being here with us tonight, and welcome to the program.
Thank you so much, Peter. I'm Dr. Mitzi Williams, and I am so excited to be here with everyone tonight, and I thank you for taking out your time to talk about this very important topic, and I hope that everyone learned something, and I'm really looking forward to getting into the discussion and into the questions that we have at the end of this discussion. So we will just hop right into it. Okay. All right, and I also want to thank MSAA and also our industry sponsors for sponsoring this program and allowing me to reach and speak with all of you this evening. So let's first kind of talk about what multiple sclerosis is, and I assume that many people who are on the call either have multiple sclerosis or have family members or friends or loved ones who have multiple sclerosis. But I think that before we kind of talk about diversity, we kind of have to talk about what the disease is. So this is a graphic or schematic that looks it's supposed to look a little bit like our nerve network or nerve endings. And so multiple sclerosis is essentially an autoimmune disease, meaning the immune system, the part of the body that normally attacks viruses and bacteria, it gets confused, and for some reason, it attacks a good part of the body. With each different autoimmune disease, there are different areas of the body that are attacked. So other common autoimmune diseases include, for instance, lupus, or rheumatoid arthritis, and multiple sclerosis. And so when we talk about MS, the target is the myelin or the coating of the nerve. So if we look at this schematic here of this nerve, we can see the little white areas. And so when we see these little white areas on the nerve, those are the areas that are protected or covered by myelin. And what myelin does is it makes the signals run quickly so that when we want to do something, if we want to say something or speak or move, then our nerve networks respond very quickly and we're able to do those activities normally. But when those nerves are affected, the signals essentially are slowed down. And depending on the severity of the damage, sometimes those signals don't work at all. And so we see the symptoms related to multiple sclerosis due to different areas of the central nervous system that are attacked, and that includes the brain, the spinal cord, and the optic nerves. So depending on the areas that are attacked, we see different symptoms, whether it's numbness or tingling, whether it's fatigue, whether it's bowel and bladder issues. Each of those is specific to different areas of the central nervous system that are attacked. So that's kind of a basic general definition of multiple sclerosis. But when we talk about multiple sclerosis, even though we see this graphic, and I like this because it explains some of those symptoms, but it also is so much more than just the symptoms, right? There are there's a very widespread impact of MS beyond just the physical body. It certainly can affect someone's role within their family. It could affect their interactions within their family. Depending on the symptoms, they sometimes can affect someone's ability to work or to care for themselves. And so it's also very much affected by the other people who are around, people who are care partners or care supporters. And so it's not just about the physical symptoms, but there's also widespread psychological and emotional impact related to multiple sclerosis as well. Now, it's very interesting because I just read an article that talked about how the prevalence or the occurrence of MS has increased significantly in the past 20 years around the world. And so the most recent articles or research suggests that there are about 1 million people living in the United States with multiple sclerosis, which that number is increasing significantly over time. We also know now that it's 3 times more common in women than men. We previously used to think that it was more common, that it was 2 times more common. And in some populations, such as African-Americans, it may even be 4 times more common in women than men. And there are many theories surrounding that related to hormones, but there's a lot that we don't know. And I think the other important thing is that's the second leading cause of neurologic disability in young adults, the first being trauma or car accidents. And I think this graphic here is kind of alluding to what we're going to get into further into the talk, is that there are many different people who are affected by multiple sclerosis. Now, traditionally, when we think about the face of multiple sclerosis, there is a face that comes to mind for many of us as healthcare providers, especially in different parts of the world. And this is the most common face. So traditionally, multiple sclerosis has been thought of as a disease that primarily occurs in young Caucasian women or young women of Northern European descent. And if you think about the disease and how it occurs globally, that is still the primary group of people that gets the disease most commonly around the world. And so when we look at the prevalence of MS and we look at places such as the UK, we look at Scandinavia, Europe, and Canada, we can see that there's pretty high prevalence. So in the UK, it's thought to be between 90 and 190 per 100,000, right? And we can see in the US, we're talking about 30 to 150. So we can see in these countries, in the UK and in Scandinavia, there are higher numbers, or there's a higher prevalence of multiple sclerosis. However, when we look in the United States, interestingly enough, in the past 5 to 7 years, there has been research suggesting that MS may be, the risk for MS may be up to 47% higher in African-Americans, which is driven primarily by African-American women being diagnosed. And so this is what leads to a lot of the interest in research about understanding different populations and understanding why we may be seeing the disease more overall, but also in some of these populations. So when we look at the prevalence of MS, one of the interesting things is that if we look at a group of people, we do try to go back and look at their country or place of origin and kind of compare how people may be doing in, for instance, in the U.S. versus how people are doing in their country of origin. One of the difficulties with African Americans here in the U.S. is that the genetics and the mixture of genes is so there's such a mixing or admixture of genes that there's not one particular place that most African Americans can say that they're from on the continent of Africa. But interestingly, when we look at MS, for instance, in the South African population, we can see that the prevalence is actually extremely low. So if we go back to look at the European population, if we go back 2 slides to look at the European population, we see in the UK 90 to 190 per 100,000, the US 30 to 150. But if we look on the continent, especially in South Africa, we can see that even in the white South African population, the prevalence is very low, 13 per 100,000. And in people who are considered colored, which is of mixed genetic background, 3 per 100,000. And after many years of literature and research, there have only been 6 to 10 cases reported in Black South Africans, right? And very occasional cases in Black Africans in South Africa. So it's very interesting because we see that the prevalence is very high here in the U.S., but certainly in Southern Africa, at least, we don't see it very commonly in Black Africans. So let's take a look at some of this data. So looking at, this is data from 2012 or 2013, and this is a study looking at Gulf War veterans, and they looked at the incidence rates of multiple sclerosis, and they separated by different ethnic backgrounds. And so we can see here the box surrounding the Black patients who were, or the Black people who were involved in this cohort, and we can see that when we look at the top bar, we see, when we look at the middle here, we can see that white males, the incidence on the far right was about 7.28. We can see in Black males that was higher at 8.41. We can see that white females, it was 25.79, but in Black females, 26.34. And then the total prevalence in whites, 9.32 versus 12.13 in Blacks, which is very interesting because, again, traditionally here in the U.S., we did not think that African Americans developed MS as frequently. And we'll come back and talk a little bit about the Hispanic population later. And so that leads us to the next question. So what does it mean to be African American? Again, when we look at disease and we look at characteristics, we're often able to go back to a place of origin and kind of look at how the disease behaves and the people here in the U.S. may have descended from. And again, it's very difficult in African Americans because of the admixture of genes. And I don't know if any of you have done Ancestry.com. My husband and I did it, and I think the largest percentage that came from me from any country was about 20%. And so it's difficult to really kind of match up what the country or place of origin is with kind of the genetic mixture here in the U.S. And so I think the other difficulty with looking at what does it mean to be African American is that African American can actually mean several things. Can mean people who were descendants of the slaves who migrated here through the slave trade, or it can be a person actually who was born in Africa and migrated here to the U.S. after they were, born in, either children or adults. And so those are two very different populations. And so the other thing that's very important is that we're eventually going to have to get to the point where we can define ethnicity on a more genetic or simple basis, so that we can be saying the same thing when we're talking about African American, because some African Americans may have 80% African genes. It's averaged that 70 to 80% of the genes are from African origin and maybe 20% from European ancestors, but we really need to understand that aside from people just identifying themselves as African American. So let's talk a little bit about clinical characteristics of MS in the African American population. So there's a body of research that's been emerging over the past 10 to 15 years that's tried to describe MS and if it behaves differently in different populations. And so this is a seminal paper that was published in 2004 by Dr. Bruce Cree, who has done a lot of the early literature concerning looking at African Americans with MS. And what they found was that there seemed to be a more aggressive course of disease. There was a shorter time to walking disability, which was averaged 6 years earlier to a cane or wheelchair than their Caucasian counterparts. There also seems to be a higher occurrence of transverse myelitis, and those are lesions in the spinal cord that can cause more motor disability. And also, African Americans in this group were more likely to have motor symptoms at onset. And it was a pretty large cohort of at least 600 patients, 670, I believe, African Americans, which is as large as any study that we've seen. And what else do we know? So when we talk about poorer outcomes, there are lots of things that can play into or lead to poorer outcomes. So certainly it could be some type of genetic basis or difference in how the disease behaves in certain groups, but we also have to look at things like socioeconomic status. We have to look at access to care. And this was a study looking at racial disparities in neurologic care, and it was not just focused on multiple sclerosis. It looked at many different disease processes, including stroke, epilepsy, etc. And interestingly enough, the study found that African Americans were 30% less likely to see a neurologist in clinic if they had a chronic neurologic issue. And also, again, you can see from this slide, I'm not going to read it to you, that there was more care in the emergency room, more inpatient stays, and more hospital expenses. I think the difficulty or the disheartening thing is that there was a slide that I used to use in my talks 10 years ago from 2008 that essentially said the same thing. And so we're seeing this kind of rise in the prevalence of disease. We're seeing that there potentially may be worse outcomes, but we're still seeing that people don't have access to neurologic care, which certainly could be affecting some of the outcomes that we see. And when we look at other measures like brain MRI measures and also look at retinal atrophy or visual changes or vision loss, this is a study that was published just last year that suggested that progression was significantly faster, thought to be 2 times faster in African-Americans, both in brain MRI lesions as well as in visual changes. And there was atrophy or shrinkage of the brain that was faster in the African-American population. And also there appeared to be more atrophy or shrinkage in certain areas of the brain that could affect cognition more adversely. What about mortality? This was an extremely interesting study published by one of my friends and colleagues, Dr. Liliana Amescua, which talks about mortality. So again, when we're looking at the overall population, we can see that if we look at the light blue line, that's kind of the highest line here toward the end, we can see that overall, the people of Northern European descent, this is here in the U.S., and these were people whose primary diagnosis on their death certificate was MS, so they were thought to have died related to MS or complications of MS. We can see that overall, the white population did have the highest mortality, but if we look a little bit further over to the left, we can see that at younger ages, African Americans had the highest mortality rate. So we're talking looking like from age 15 pretty much to about age 40 or a little bit over 40, that mortality was higher, which suggests that there may be more disease burden earlier on in the course of disease, which may be leading to higher mortality rates. So let's kind of switch gears and we'll talk about MS in the Latino or Hispanic population. And so what do we know about MS in the Latino or Hispanic population? There are studies that suggest that the age of onset or when MS starts is a little bit younger in that population. But overall, the risk of MS is lower than in Northern European groups. They are also more likely to have optical spinal MS, which is what we call MS where it primarily or disproportionately affects vision or the optic nerves, and also the spinal cord, which is the type that we see in African Americans. And I'm sorry about this line that's listed twice, but we do see what we call longitudinally extensive spinal cord lesions. So meaning when we see lesions in the spinal cord in some of our Latino or Hispanic patients, they appear to be longer and a little bit different than what we typically see related to MS, and more typical of the lesions that we see with a similar disease called de Vick's disease. And so essentially that means that we as neurologists have to be very careful about making the accurate diagnosis, because MS can look a little bit different on imaging in this population. And then I think, interestingly enough, another issue that may affect level of disability in the Latino population is the timing of migration to the United States. And so it appears that the earlier people migrate, they may have disproportionately higher levels of disability. Okay. And again, the same thing, what does it mean to be Hispanic or Latino or Latinx, as some people call this population? What does it mean to be Hispanic American? And it can mean many different things, right? So unfortunately, we kind of lump people into one category, but for instance, my friend Dr. Amescua sees primarily a Mexican population. I have another colleague, Dr. Angel Chinea, who sees primarily a Puerto Rican population, and then I have colleagues in Florida who may see a Cuban population. And when you look at the genetics in these groups, they're very different. So for instance, there have been studies looking at the genetics of the Mexican population versus the Cuban versus the Puerto Rican, and the Puerto Rican Rican population has a higher percentage of, for instance, African genes. And so there are things that we can begin to understand about how the disease behaves and how that may be affected by genetics. But again, it comes from looking at things on a more scientific basis and not just based on how we identify ourselves by how we look on the inside, on the outside. And what about the prevalence of MS? This study just looks a little bit at the prevalence of MS in different countries. Rio de Janeiro, 5 out of 100,000, right? Very low. Remember, in the UK, we saw that it was 90 to 190 per 100,000. In Sao Paulo, 14 out of 100,000. Uruguay is the highest, 30, which is similar to the U.S., but again, the mass majority of those people may be of European ancestry, and then in Cuba, 8, right? So again, much lower prevalence in countries that patients may migrate from. And when we look at our incident study, the same one that we looked at in African Americans, we can see the numbers are much lower. So again, in the white male group, 7.28, in the Hispanic male group, 6.59. Females, white females, 25.79 versus 17.04 in the Hispanic female group. And so we can see a lower incidence of MS in this group, as we discussed earlier. So what about difference? And again, I alluded to this a little bit earlier. There are genetic differences that may affect the way the disease behaves. So the optical spinal form of MS is what oftentimes we call the Asian variant of MS. So looking at those differences in the different percentages of genes that come from different backgrounds may help us understand why the disease may behave in certain ways and why people may or may not have aggressive disease. But the important thing is that we need to collect that information to understand the disease process better. All right. And what else do we know about MS in the Hispanic population? Again, this is some of what we talked about: younger age of onset, more optical spinal disease or disease that affects the vision and the spinal cord, longer spinal cord lesions. But the progression of disease is similar to what we see in the Caucasian population. So there is not the same narrative of more aggressive disease that we have seen to some extent in the African-American population. And obviously there are more studies that need to be done. We did a paper, actually that is the next slide. There was a paper that my colleagues and I was fortunate to contribute to that just kind of gave an overview of MS in U.S. minority populations, and we published this in 2015. And when we did a literature search at that time, out of over 50,000 articles that had been published about multiple sclerosis, there were only a little over 100 that were about MS in minority populations. And so that tells you that there's really not a lot of data. And much of the research that we have is what we call retrospective, meaning we take a group of people and we kind of look at where they are right now, and then we look back to see how they did over time. When a better way to do research is what we call prospectively, where we start everybody on the same playing field and give everyone access to the same type of care, and then we see if the outcomes are similar. And so although we have some data that suggests that this is what the disease behaves, we certainly need more information, and we need better research studies to understand what's going on. This is a study looking at mortality. Again, this is going back to the mortality study. And what we saw, again, was that whites and females were overall more likely to die from MS. African Americans are dying at a younger age. And again, the key is that we need further investigation. So even though we see these things, it's very unclear what part other issues such as access to care, socioeconomic status, insurance, even in some cases transportation for people who live in rural areas. There are many things that affect outcomes, and we need a better understanding of why we're seeing these differences, and we don't have all those answers yet. So what about our clinical trial experience? So this is very important because clinical trials are basically our major trials that lead to medications getting approved here in the U.S. and around the world. One of the difficulties with many of our clinical trials is that oftentimes the majority of patients are enrolled outside of the U.S. And even of those that occur or are done or have groups in the U.S., there are very small numbers of minority patients in these studies. And again, these types of studies are very ideal for obtaining information because everybody's on the same playing field, right? So often the care is very good care because you're able to visit the doctor frequently. And also the care is often free. And people have access to MRIs, they have access to doctor's visits, there's treatment if they have relapses, and also there's treatment for disease modification. And so clinical trial enrollment for African Americans is often somewhere around 1 or 2%. So essentially, when we look at most of our studies, out of over 1,000 people in most of our large phase 3 trials, somewhere between 1,000 to maybe 1,300 people, we usually have somewhere between 10 and 30 African Americans in those studies. And unfortunately, in some groups, actually people weren't asked about Hispanic background or ethnicity, so some of the data was not captured because people weren't asked. And so I think that it's important that we start paying more attention to these things so that we can understand the disease process better. And again, clinical trials are not the type of research for everyone, but there are many ways that people can get involved, and we'll go into a little bit more detail about that later. So why is this even important? For a couple of reasons. One, minorities are underrepresented in clinical trials and research, and so there are differences that may be missed in how the disease behaves. And also, the lack of diversity could certainly impact our ability to generalize the findings of our research, right? So if a whole group of people is not included, how do we know that the disease or the medications behave similarly, or that they may not have slightly different side effects or different methods of action if we don't have a diverse population of people included in our research? And what are some of the other factors that may affect or may be unique or specific to patients of African descent with MS? And so there are a couple, and some of these we've touched on. So certainly lack of diversity in clinical research, socioeconomic status, access to care. We saw the study where 30%, which is a significant proportion of people, still don't have access to neurologic care. There also is distrust of the healthcare system, and there has been a very kind of long and sordid history of unfortunate interactions in the healthcare system with African Americans during experimentation and other things like that. So that often can affect willingness to participate in research or even sometimes take medications, and also religious beliefs and practices, which may in many ways be helpful in helping combat issues such as depression, but also could potentially affect people's treatment choices as well. And so those are things that I counsel my fellow colleagues and providers to be aware of, so that when we're interacting with people that we take these things into account. And similarly with the Hispanic or Latino population, again, lack of diversity in research. A unique issue is immigration status, which we alluded to could potentially affect disability levels and outcomes. There may be language barriers depending on the time or how long since someone has migrated to the U.S. And also religious beliefs and practices may play a role. And my colleague, Dr. Matthew, can talk more about that in terms of mysticism or other ideas that may affect interaction with the healthcare system. And so sometimes there are unique issues or areas that need to be discussed or taken into account, and I think that it's important for people living with MS to talk about these things with their physicians, but also for us as providers and healthcare professionals to understand some of these unique issues and make sure that we don't gloss over them when treating people of different backgrounds. Now, let's switch gears a little bit and talk for a few minutes about pediatric MS. And so this is a really interesting group. And it's estimated that somewhere between 8,000 to 10,000 children are diagnosed with MS. I often get asked, what's the youngest patient that I've had with multiple sclerosis, and that was an 8-year-old. And so it's difficult to diagnose in very, very young children because our brains continue to develop over time. So sometimes at very young ages, if children are having neurologic disease or neurologic symptoms that may be typical of MS, sometimes it takes a while to see the brain form normally before we can make that diagnosis, because abnormalities on MRI may be common at that age. Also, if we think about people who are adults with multiple sclerosis, it's estimated that somewhere between 10 to 15,000 people have had at least one symptom of MS when they were younger than the age 18. And I've had countless patients who've come in who said, Dr. Williams, when I was a teenager, I had this issue, or when I was younger, I had this issue, and we didn't think anything of it. And it very well could have been the first symptom of multiple sclerosis. So, and 2 to 5% of those diagnosed with MS, as I said, had onset prior to the age of 18. And also we have to be careful because children may have symptoms of MS that are a little less common, like mental status changes or seizures, which are not common presenting symptoms with MS with adults. So with adults, we see more things like numbness and tingling or weakness, sometimes symptoms of stroke, loss of vision, but we have to be careful because sometimes we see those uncommon changes in kids. And I think what I didn't put here on the slide is that also there is a form of demyelinating disease that occurs in children called ADEM, and we have to distinguish that from MS because that may be a one-time event that may not recur. And so we have to be careful not to treat children for a chronic disease when they may have a one-time illness. What else do we know about pediatric MS? So most children are diagnosed with relapsing remitting. We don't see a lot of primary progressive MS or progressive MS from the start in the pediatric population. They do tend to have more frequent relapses, and they may have a slower progression of disease overall, but do accumulate more disability at younger ages, obviously because they start with the disease earlier on in life. And again, we may see some of those less common symptoms, such as seizure, which generally occurs in about 10% of the MS population, and mental status changes, which are not a common presenting symptom, meaning someone gets acutely confused. So to distinguish that from cognitive dysfunction, which can occur in most people with multiple sclerosis. And so what about treatment? So currently there is only one FDA-approved treatment for pediatric multiple sclerosis, which is fingolimod, and that was just recently approved. So there was a huge issue in treating pediatric patients because there were no medications approved, and oftentimes it was difficult to get them approved. There was a recent study there was a recent presentation at our National Congress, the Consortium of Multiple Sclerosis Centers, CMSC in Seattle, and I went to a presentation where they talked about pediatric MS and suggested that up to 65% of children diagnosed with MS may be untreated. And so I think that that's a very kind of shocking statistic, but important because, you know, obviously we have to make sure that we're addressing this population as we can see that they can accumulate disability early. And also it suggests that injectable therapies are the most commonly prescribed in this group, likely because of safety concerns. But again, we don't have enough information to really understand the disease process and how these medications may work in children. Fortunately, we do now have one therapy that's approved, which is at a dose that's different than what we give for adults. And then there's several other oral therapies that are now being looked at in pediatric populations so that we can make sure that we're safely treating children with multiple sclerosis. And what special considerations are there for pediatric MS? So certainly the psychosocial impact of diagnosis. So that's something that we have to be aware of in adults, you know, but certainly in children who are interacting within the school system. There certainly could be issues needed with accommodations at school for cognitive dysfunction. We often write letters for our adult patients for accommodations at work. Because of difficulty, but certainly it can sometimes be more involved when we're talking about school. Most commonly, I write letters for accommodations for children who are in college to have extra time taking tests, but those are all things that we need to take into account. And it's really important with children to have multidisciplinary and team-based care, and that they have some type of connection to other children with multiple sclerosis. And that's something that I encourage all of my patients to do, is to connect with other people with MS. But certainly for children, they can feel very isolated because, you know, as we saw, 1 million people, grown-ups, for instance, in the U.S. may have MS, but 8,000 to 10,000 children is not very many. So it's important to find ways for them to connect and receive support. And so when we think kind of in the overall picture, kind of what are some of the challenges to care? in special populations, right? So we have to balance the knowledge of the phenotype or the symptoms, the way the disease presents, with our treatment decisions, whether that is looking at people who may potentially have more aggressive disease or looking at side effect profiles for a younger person, let's say, who's maybe 10 or 11 years old. So we have to take all of those things into account. It's also important to examine genetic, socioeconomic, and cultural factors that may influence access to and delivery of care. Because when we look at outcomes and see that maybe one group is doing more poorly than another, certainly there are many things that play into that system that may lead one person to have a poor outcome versus another. And then I also think that poor diversity in clinical trials can potentially affect our application of knowledge of MS in various populations, including the African-American population, the Hispanic population, the pediatric population. And one population that I didn't touch on, but I'll take a minute to address here, is our aging or more mature population, as I like to call it, although age does not equal maturity. But I do think that that's another group that's very underserved in the MS community. So if you look at many of our clinical trials, most of our trials stop at the age of 55. And we're increasingly finding people who are diagnosed with MS over age 55, people who are living longer and living well with MS, well into their 60s and 70s. There's a very slight decrease in the lifespan of people with MS, but often people live a very full lifespan. And so we have to look at how our medications affect this population for a variety of reasons, one being that as we age, our immune system also ages. And so we have to look at how drug interactions may work in terms of infections or other side effects and issues because our immune systems and our immune cells are aging. And so I think that that's another population that does deserve a lot more attention. Also, I think that there are groups looking to see if medications are needed over a certain age. And so there are a lot of questions that we have. So there are many underserved populations in the MS community. And so certainly, you know, in one talk I can't exhaust all of those groups, but that's another very important group, MS in the aging population. And looking just at a couple other things, when we talk about considerations in management of minority patients with multiple sclerosis, it's important, and I put this slide here to talk about, you know, the onus on healthcare providers, is that we have to make sure that we're establishing a trusting and therapeutic relationship with our patients, directing people to culturally appropriate education materials where needed. And I think that we also need to make sure that we closely observe people who have aggressive disease so that if they are starting to have issues, we either refer them to the appropriate person or talk to them about different treatment options and provide information about clinical trials for all of our patients. And I think also it's important as people living with MS or advocates or family members of people living with MS to know that you are your own best advocate. So I encourage all of my patients to ask questions. I also encourage them, if you're having an issue or things that we need to discuss, if you feel like you're getting worse, it's okay to ask questions and bring that to your physician's attention. If you feel like you are still not continuing to get better, it's okay to ask for a second opinion. I have people that often come to me for a second opinion or may go see someone else after they see me. But the therapeutic relationship with MS is a very close relationship. We often spend a lot of time with our patients. We have a lot of interaction with people living with MS, and you have to feel comfortable with whoever is treating you. And so what are some solutions, or what are some things that are being done to improve these things? So there are a couple of different initiatives I want to talk about very quickly. The first is the MS Minority Research Engagement Partnership Network. Say that 3 times fast. This is a great group of people that I was able to connect with through a grant from the Pecori Foundation, where we actually developed toolkits for people living with MS as well as for researchers to talk about culturally appropriate ways to improve diversity in clinical trials. And there are other projects that we're working on, including what I call a myth-busting tour, where we talk about some of the myths related to clinical research in the community and try to engage people to get involved in the research process. And there's a website for that. Also, coming soon to a office near you is the National African-Americans with Multiple Sclerosis Registry. Some of my colleagues and I, myself, Dr. Annette Okai and Dr. Annette Howard in Texas, have all been diligently working on getting a registry started for African-Americans. So that will be coming and up and running in the next couple of months. And that will be something very exciting to learn more information about the African-American population and understand how we can move the needle forward in terms of increasing equity in care and decreasing some of those disparities, as well as, most importantly, improving outcomes. And then finally, if you want to find me, you can follow me on social media. I am very active. If you're on Instagram, I am the Nerdy Neurologist, although I am pretty nerdy, but I don't look nerdy. But anyway, so the Nerdy Neurologist, and then Dr. Mitzi Joi, MD, I do educational videos about multiple sclerosis to help people understand the disease process and also to talk about topics that are important. Sometimes I take topics from my audience, and so I post those on my YouTube channel and on my IG channel. And also I have a website, Dr. Mitzi Joi, MD, where you can learn more about multiple sclerosis, and there's a newsletter there. And also I wrote a book that I did not put here called MS Made Simple. And finally, my last question and my last slide before we go into questions says, all I need is peace, love, and a freaking cure for multiple sclerosis. Thank you so much for your time and your attention. And I will hand it back over to Peter, and we will go through any questions that you all have. Thank you so much.
That was great, Dr. Williams. Thank you so much for that. That was very insightful, a lot of great information, and some of those research stats are very, very telling for sure.
Thank you.
Yeah, absolutely. We had a number of great questions that came in, so I'm going to run through them now. So one question was talking about the issue of heredity in MS. So it said, I was diagnosed in 1999. And my daughter was diagnosed in 2009. Is MS hereditary?
Great question, and one that I get asked very frequently. So the answer is yes and no, okay? So the answer is no in terms of there's not a direct pattern of inheritance that's been identified, right? So if we think about a disease like sickle cell, for instance, we know that if mom has a certain gene and dad has a certain gene, right, and they have children, we can predict that potentially 1 in 4 of their children has a chance of getting both of those genes, right, that cause a disease. With multiple sclerosis, the genetics is a lot more complex. And so there are over 200 different genes that have been associated with increased risk for MS. And I have some families where multiple people have MS. There may be a parent and a child. There may be siblings. But I have just as many families of people that I see where that person is the only person, right? So there's not a reliable genetic component that we know of with MS. But certainly there are some families where multiple people have either MS or multiple people have autoimmune diseases. So for instance, if there aren't 2 people with MS, there might be an aunt who has lupus and then a cousin who has MS or someone else that has rheumatoid arthritis. So those types of things can run in families. And so there's a lot of work that we need to do in terms of understanding, but we know that genetics plays a part, but it's not telling the whole story. Because when you look at twin studies, right, which are kind of the ultimate, because they have the same DNA, right? So when you do look at what we call homozygotic twins, right, if one has MS, there's about a 25% chance of the other one having MS, right? And so if genetics were the whole story and you have the exact same DNA, you would expect it to be closer to 100%. So it does play a part, but certainly does not tell the whole story. Thank you for that question. It's a great question.
Yeah, excellent question. Another question is, are the MS therapies as effective for the African-American and Hispanic communities as they are for the Caucasian community?
Absolutely. Also a great question and very common one as well. And so when we talk about efficacy, again, the numbers of people in our clinical trials are very low in terms of minority population. So as I said, at least for the African American populations, we average maybe 10 to 30 people. I think the largest trial had maybe about 55 African Americans in that study. And so what we try to do after studies are done is that often, scientists or statisticians will go back and look at different populations to see if they behaved similarly. And so from the studies that we have, with most of our medications, when they've gone back and looked at the small numbers of people, most of the time they did seem to have equally effective the treatments did seem to be equally effective, but the difficulty is it's very hard to make a big generalization out of 10 people, right? So the honest answer is we need more information, but from the small amount of information we have, there does seem to be similar efficacy with most of the medications in minority populations.
Okay, great, thank you. Another question, for Black males with relapsing, remitting multiple sclerosis, what is the percentage of that moving towards secondary progressive or primary progressive MS?
Great question. So for African American males, there's really not, so when you look at the data about kind of characteristics of MS in African Americans, one of the things that was found in one of those Sentinel papers, the one from 2004 with Dr. Bruce Creed, was that there didn't appear to be much of a difference in the subtypes of MS, right? So there did not appear to be, for instance, more progressive disease in African Americans, more primary progressive, or more secondary progressive disease in African Americans. However, again, the actual progression once someone develops MS does appear to be faster in the African American group. So it's not that there's a larger percentage of folks who have more progressive disease, it's just that once people develop the disease, the progression does appear to be faster. And people do appear to progress more quickly by several measures, MRI as well as physical disability and vision changes in that group.
Excellent, thank you. So this talked about some of the research slides that you had. When including different ethnicity groups in your research, how do you classify people that carry genes of various nationalities? For example, my father is from India, my mother from England, and her grandparents come from different countries too. There are many people who have mixed nationalities. When answering questionnaires, I normally instruct myself to as white, as I was born in the Middle East.
And that's excellent. That's excellent. And it kind of gets to the heart of some of the issues that we have. So I think that we as scientists have to find better ways of capturing information, right? Because oftentimes, as you said, people have multiple ethnic backgrounds, right? And so it's not fair to kind of make somebody choose one. But we have to find better ways to capture the data. And I think that there are many of us who are looking at these issues and understanding that in order to understand this process better, we also have to make some changes as a scientific community, right? So it's not just about people getting involved in the trials, which is important. It's about finding better ways to identify who is involved in the trial because, again, most of what we classify as African American is based on phenotype, what someone looks like on the outside. And I think that we also have to find better ways of capturing the data genetically so that we can understand what it means if someone has a certain percentage of these genes versus those and how they may affect the disease process as well. So we have to do a better job of getting that information and making it more accurate so that people can, talk about or inform us of multiple ethnic backgrounds that may be involved in their heritage.
Very good, thank you. Earlier you had a slide or two on mortality, and this question had people have died from MS. What exactly is the cause of mortality?
Also excellent. So generally, when people die of complications of MS, it generally is not necessarily from a lesion or a relapse. More commonly, we see people get infections, related to lack of mobility. So the same reasons that people who are extremely disabled usually pass away. It's usually some type of infection, a pneumonia or bed sore or maybe a fall, breaking something of that nature. But it's very rare that someone will actually have a lesion. If you can still hear me, it's very rare that someone will actually have a lesion that strikes a certain area that makes them, for instance, stop breathing, right, or have a heart attack. So that's usually not what happens. It's usually related to complications from severe disability, whether it's some type of infection or some type of injury due to imbalance and fall.
Okay, great. And in terms of causes of MS, what role does the environment and or stressors play?
Absolutely. So the environment does play a role. I think that, again, there's still a lot that we have to learn. So we know that people who live in certain areas don't have a very high risk for MS, right? So we looked at MS in South Africa, right? Almost non-existent, even in some of the Latin American countries. Almost non-existent, but when we look at the UK, we look at US, we look at Scandinavia, we see much higher risk or prevalence of multiple sclerosis. So could there be some type of virus that we're exposed to? Could there be something related to our diet or the things that we're taking in? There's lots of research that's being done looking at what we call the gut microbiome, which is basically all the bugs in your gut, for my scientific term, but all of the different organisms, and we know that the gut microbiome essentially educates the immune system. So potentially could we be eating and could our diet be causing our immune system to attack us? And the answer is there's a lot of research looking into it. I think that most of us as scientists and people who treat MS or work in the MS community would agree that there's some environmental factor, but it may not be the same factor in each person. It may be multiple different ones that may be affecting people to, let's say, make one person develop MS versus another. So we have to figure out what some of those factors are. We do know that there are some modifiable risk factors, right? So one is smoking. We know that smoking can affect risk for MS. We also know that smoking can lead to faster progression with multiple sclerosis, so that's one modifiable risk factor. We also know that obesity is now becoming a more well-recognized risk factor for multiple sclerosis. And so there are several modifiable risk factors that can affect disease, but also there are likely some other environmental factors that we haven't fully identified. One that is also very common is Epstein-Barr virus. So many people who have multiple sclerosis have been exposed to Epstein-Barr virus, the one that causes mono, but again, everyone that gets mono doesn't get MS. So it's a very complex process, and many people are, diligently looking into identifying what some of those factors may be that affect risk for disease.
Okay, thank you. I heard that there is a high risk of incidence of MS in Puerto Rico. Do you know why?
So great question. Again, the U.S. has a higher risk, so U.S. territories, right? So when we talk about North America, the risk is definitely higher than in many parts of the world. So again, potentially could be an environmental factor related to that. Also, if we look at the Puerto Rican population, they do have a significant percentage of African genes in their ancestry. I don't know if that's playing a part or not, but it, as being part of a U.S. territory, would have a higher risk of MS. I do not know of Puerto Rico having a higher risk than, let's say, the U.S. in general. So I don't know of data that points to that, but certainly North America does have a significantly higher risk than many parts of the world.
Okay, we have time for one last question. Are there therapies in the pipeline to address remyelinization?
Absolutely. And so, one of the difficulties with the treatments that we have, so the treatment landscape for MS has changed dramatically, even in the past 10 years or so, right? So, we used to have only injectable therapies. Now we have pills. Now we have infusions. And so there's almost a new medication almost every year. And some years there are 2 new medications that are approved. And so with all of those medications address similar things. So we basically can prevent new things from being broken, so to speak, but we don't yet have medications that fix the damage that's already been done. There are several therapies directed at remyelination that are being looked at. There was one that unfortunately did not meet its primary criteria of affecting relapses, and many of us were very disappointed about that when those results became available last year. But it certainly is still being looked at, and then there are several other medications that are in very early stages of research that are looking at ways to repair the myelin that's already been damaged. So yes, the short answer is yes. And we've had some failures in that regard, but people are still diligently working on ways to try to fix the damage that's been done.
Well, that's great news to hear. And thank you so much for the responses. They were excellent questions that came in. Very, very good with
Absolutely.
that.
Absolutely.
So this does conclude our webinar, The Many Faces of MS, Exploring Diversity and Differences. I would like to once again thank Dr. Mitzi Joi Williams for excellent presentation on this very important topic, as well as our supporters Novartis and Celgene for not only this webinar, but other activities as part of our MS and the Family campaign. As a reminder, this webinar will be archived. We will work diligently to get it up, maybe in a couple of days, onto our website, so please check back in with us on that. And I ask if you can take the time, very brief, to fill out an evaluation survey that will immediately follow this presentation and provide us with your thoughts and feedback and suggested topics for future webinars. So on behalf of MSAA and Dr. Williams and everybody attending, thank you so much for watching.